So good morning, good day, and good evening, everyone. On behalf of Mending Kids, I'm Isabel Fox, the Executive Director. I'd like to welcome you to the 4th Mending Kids Virtual Educational Symposium on the diagnosis and management of common arrhythmias in children and adults with congenital heart disease. And I'd like to thank our organizers and moderators, Dr. Berman from Children's Hospital Los Angeles and Dr. Evan Zahn from Cedars Sinai Medical Center. I'd also like to add that this symposium in part is made possible through a grant from the Edwards LifeScience Foundation's Every Heart Beats Matters program. And as an organization that provides critical surgical care to children all over the world, we strive to also provide exchanges of knowledge to keep us all connected and elevate the standards of care. So without any further ado, I'd like to have Dr. Berman introduce the rest of the panelists, and also know that during this symposium, you will be able to, through the Q&A chat program on your screen, pose questions when they come up, and they will be moderated at the end of the presentations, at the end of the symposium. And also we will be sending you a survey that is so critical to us being able to provide these symposia. So please do your best to fill them out in a timely manner, because it means everything to us to be able to keep these going for you. All right, thank you very much.
Isabel, thank you for that wonderful introduction. And I'm going to keep it short and sweet so we can dive into the meat of the matter. But we're very excited about our 4th symposium now. We welcome all of our attendees from within Dar es Salaam and Tanzania and from around the world. We have put together a number of speakers from across the United States who are all pediatric electrophysiologist specialists to speak on some of the topics that have been asked of us. And we are excited to get started. I'm going to hand it over to Evan Zahn to make the introduction of the first few speakers, and then I'll take it back from there.
Okay, I just want to wish everybody a warm welcome. Good morning, good afternoon, good evening, depending on where you are. It is so nice to be back together with our East African and African colleagues. Really happy you guys joined. I want to congratulate Darren primarily and Christina, who put together this really wonderful program. This is a really expert panel of fantastic congenital electrophysiologists that are really going to take you through congenital arrhythmias, literally from birth to old age and everything in between. It's a fantastic panel. I just want to emphasize what Isabel said. Please ask questions. This is meant to be interactive. We will answer the chat as time allows, either after the speakers or at the end. And welcome everybody. I hope this is of value to you and you enjoy it. And with that, I want to introduce our first speaker, who is Dr. Henry Chubb. Dr. Chubb comes to us from Stanford University, one of the premier congenital heart programs in the United States, and is going to talk to us this morning about common neonatal arrhythmias. Henry, I turn it over to you.
Thank you very much indeed. Can you hear me okay then?
We can hear you well.
Perfect. So I'm just going to share the first slide, and hopefully that comes up cleanly for all of you. Great. Okay, well, thank you. So I will try to keep this moving swiftly. This is going to be a bit of an overview of all of the arrhythmias, but I'll be focusing.
Me, Henry. Pardon me. I'm sorry to interrupt. The slide is kind of zoomed in, so it was different.
Thank you for pointing that out. Yeah, let me, as always, despite all of our IT work, something changes. So let's stop that share for just one moment. Let me adjust that and move it to a different screen. See if that is better. And here, share, and that. Is that looking a little more
fantastic?
palatable?
Yes, fantastic. Thanks.
Perfect. My apologies. So thank you. So let's take an overview, and I'm just going to take a step back before we tackle all of the congenital arrhythmias, if that's okay, just to talk briefly about the cardiac cycle and the electrogram. So as we all know, the sinus node is the initiator of the normal heartbeat. It spreads electrical activity across the upper chambers of the heart. And then there's that slowing as it comes across the AV node, which is what reflects in that PR segment, that isoelectric PR segment. And then very nice synchronized contraction of the two ventricles with a sharp QRS, using both the left bundle and the right bundle at the same time before we get the repolarization of the T wave. And we then look at that in 12 leads. So we have the frontal leads, 2, 3 AVF looking down from the lower parts of the heart, and then the chest leads coming around from V1 through to V6. So that's just a construct in your mind I'd like you to have, because we'll be going through a few ECGs as we go along as well. In terms of the things we're going to look at for the arrhythmias, two broad categories, bradycardias and tachycardias. And congenital complete heart block, when we look at the bradycardias, is going to be the one that we think of most of all. Now, I'm only going to touch on this briefly because Dr. Hill will be talking about this in much more detail later on. But I think it'd be remiss of me just to gloss over it entirely. So this is relatively common, particularly in mothers with history of autoimmune disease such as lupus, and those antibodies impacting upon the development of the AV node. And so what we see is this sort of marching through of these great big P waves in this case, and then an underlying QRS complexes without any relationship to the P waves. And this is what keeps the baby alive. And I'll let Dr. Hill talk much more later on about the ways in which we manage that. But there are other causes as well of bradycardia that we should just think about very briefly. One is functional block. And so you can get blocked atrial ectopics and also long QT. So when I say blocked atrial ectopics, our normal beats come here before each QRS. But if you have atrial bigeminy, so these tight coupling of two different foci of atrial activation within the atrium, sometimes that can be so early that it does not conduct through. And this effectively creates a 2-to-1 block. And I've seen babies delivered before who've had this antenatally and delivered prematurely for concerns for bradycardia. And it turns out to be atrial bigeminy once they're born. And this tends to pass with time and is a fairly benign long-term outcome. The second is not so benign. This patient here, you can see again those P waves. So P waves effectively a 2-to-1 block, but this time the P waves are regular. And the other thing the eagle-eyed amongst you will notice is that that QT interval is really extremely long, a very long QT interval. So this is a very long QT syndrome. This is quite a malignant outcome in many cases, unfortunately, but another cause of bradycardia just to have in the back of your minds. But the main meat of this talk is going to be about tachycardias. So I'm going to move on to that now. And many of us will divide our tachycardias into the broad complex and the narrow complex. And as with all things medical, it's not a perfect dichotomy, but it works well for a lot of our categorization. So when we think about tachycardia and our broad complex tachycardias, ventricular tachycardia is the one that will come to mind first for many people. And this does occur in neonates, often though it's more of an accelerated idioventricular rhythm. So where the ventricular origin and automatic focus of ventricular activation is competing with atrial activation. So here this ventricular, these slightly broader heartbeats in each case are going very slightly faster than the atria. You can see the P waves marching through here. And then occasionally you get the P wave on time and it captures through, you get these capture beats. And again, generally the management is supportive and pharmacological, but in some cases can be quite challenging. But the main causes actually of broad complex tachycardia in our neonates is actually related to not related to ventricular tachycardia, but to other issues. And the commonest of all is aberrancy. So all of the narrow complex tachycardias I'll be talking about very shortly, all of them can manifest with aberrancy. And by that, I mean that the bundle branch, one or the other, is overly stressed by the fast heart rate. So you end up with a bundle branch block pattern. And that can then give you a broad complex tachycardia. The other one that can occur is sort of imbalances of homeostasis or drugs or toxins. And this can range from high potassium to other drugs like flecainide. So there's a patient recently that we had who was born with this horrible broad complex tachycardia here that was related to flecainide given to the mother in utero to manage his atrial tachycardia. And that gradually resolved, mainly time, a little bit of bicarbonate and some intralipid, but time more than anything, as that gradually came back to healthy narrow complex. So just keep in the back of your mind when you see a broad complex tachycardia that it's not always of ventricular origin. The most common thing will be aberrancy, but it can be one of these other mediated things as well. So let's move on to narrow complex. And this is the biggest thing. So I've spent 5 minutes talking about everything else, and now we'll spend the next 10 minutes or so talking about these narrow complex tachycardias. And when I think of these, I try to divide them in mind to those of atrial origin, so those are arising purely within the atrium, those of nodal origin, so those coming from the AV node, and those that involve both the atria and the ventricles, so coming back and round. And so when we look at those, we've got a fairly broad range, and I'm just going to work through these in a fairly swift fashion and just talk about how they look and how we manage them. Sinus tachycardia is the obvious one first, and it sounds obvious, but it's sometimes quite difficult to recognize. And I think it's important to be able to see this when it occurs. It can be swift. This one is about 215 beats per minute, but can be up to 230, 240 in the neonates at times. And the key is to look for those P waves. And you can see here, hopefully, these little P waves here, which are positive in 1, in 2, in 3, and in AVF. And if we go back to thinking about the setup of our sinus rhythm, then the sinus node is a relatively high and right-sided structure. So the activation of the atria is going to be heading in this direction from high to low. And so when we reconcile that with our leads of the 12 lead ECG, it's going to be heading towards 1, and it's going to be heading towards 2, AVF, and 3, and it's going to be heading away from AVR. So when it's heading towards that, it's going to be positive. And that means that, like in these cases, if it's positive P wave in 2, in 3 in AVF, and a negative P wave in AVR, highly likely to be sinus rhythm. And that's what we see in this case. And so we see all of those in a negative, little tiny negative P wave in AVR there, which hopefully transmits across. And the reason that's important is we need to differentiate that from atrial ectopic tachycardia. And that can occur as well. This is a slightly slower heart rate, but very clearly you can see the negative P wave in 2, in 3, in AVF. So this is coming from low to high. So if it's heading a negative in those inferior leads, negative in 2, AVF, and 3, it's heading from low to high. And this can't be sinus rhythm. The good thing about it is that the control of it is, although it can be difficult, if you can get through the initial period, then 90% resolved by the age of a year. And the mainstay for most of us will be beta blockade, but if it's available to you and this is resistant, then there are multiple other drugs that are sometimes effective. The one that generally isn't, though, is digoxin. So we've talked a little about sinus tachycardia, atrial ectopic tachycardia, and I'll now move on to atrial flutter. And this is one of my favorites. So this one here is a newborn baby, and we can see fast tachycardia, and we're looking for P waves again. We're looking for those clues. And the biggest clue is going to be here. We have a dropped beat. We're missing a QRS complex. And you can see here those P waves just continuing through at a fast rate. And even if we didn't have that, if we zoom in on, say, lead 2 here, we can sort of see this almost sawtooth fashion like that. So many would feel this was diagnostic of atrial flutter, this sawtooth pattern, often 300 to 450 beats per minute in the atria, conducted up to 2 to 1, sometimes 3 to 1. But if you give adenosine, if you want to confirm that in your mind, then you'll tend to see something like this. You'll tend to see that sawtooth pattern unfurl. And at that time, what we're looking at is probably an arrhythmia going around the tricuspid valve. I say probably because it's not many patients that have ever been taken to the EP lab to really work out exactly what's going on. But there have been case reports of doing an ablation that would address this and that actually fixing the tachycardia. I'm just going to take one moment to think briefly about adenosine. So adenosine is something that is a fantastic drug in terms of trying to both unmask and treat arrhythmias. It causes hyperpolarization, and therefore you get heart block. And for the neonates, we tend to sort of start at 100, 200, 300, and then peak out at 300 micrograms per kilo. And in older kids, go up to 500. You really want to use a large vein, bolus and a big rapid flush. You want to get a maximum concentration of adenosine reaching those coronaries and causing the AV block. You should have a defibrillator and resuscitation equipment available. And really, ideally, you should be running some kind of ECG to see what happens. That sometimes these things are a flash of an eye and you need to be able to go back. The other thing just relevant for neonates and always intrigues me is this graph here about what dose is effective, that infants actually tend to need a higher dose. So the success rate is lower at given doses in infants than in children. And yet we tend to give lower dose in infants. So you really do need to focus on that bolus and getting it through quickly. When we then think about the effect of adenosine, well, in sinus rhythm, it's going to slow down and then speed it up. AVRT, which I'm going to come to in a moment, it'll stop and then it may or may not restart. AVNRT, less relevant to neonates, but people will be talking about later. It'll stop and then may or may not restart. Atrial flutter, it will slow that ventricle and expose the atrial activity. And then the ectopic atrial tachycardia may expose the atrial activity, but some of them are adenosine sensitive, so it may stop the tachycardia, but then not, because most are automatic, it will normally restart. And then ventricular tachycardia, normally nothing. It may change the atrial activity, and then in rare cases may stop the tachycardia. But coming back to our patient here originally with the atrial flutter that we gave to, what are we going to do next? We haven't fixed the tachycardia. And here that mainstay of treatment is going to be DC cardioversion for most people. Excuse me, skipped over a slide. Just going back. So DC cardioversion. Some will try atrial pacing with an esophageal lead, and others may try loading with digoxin or even sotalol, but I think the majority would go for a straight DC cardioversion. And then the long term, actually, generally medications are not required. 90% have no recurrence, and of those that do have recurrence, 90% are within 24 hours. So if you get out of that first few days, then things look good. So it feels like we're running out of time, but most of the rest of these are less relevant. So atrial fibrillation doesn't occur in neonates. And then we're on to junctional tachycardia. So junctional tachycardia, funny nomenclature to it. Some people call it junctional tach, some JET, junctional ectopic tachycardia, some nodal tachycardia. But the key is that this is an origin from the AV junction or the HIS. And it is an automatic tachycardia that tends to get a little faster and then slower. And often there can be AV dissociation, so no conduction back from the AV node to the atrium. And so this is a patient of mine from a few months back with congenital junctional ectopic tachycardia. So you can see this fast rate coming through and these P waves, which are going slower and just marching through. Just occasionally you get a P wave here that conducts through and you get a little atrial capture beat before it comes back on. And this can be very challenging to manage at times. This patient needed esmolol and amiodarone. The brother ended up on ECMO, so the older brother, so we were forewarned what might be happening here, but can be sometimes very difficult to manage. AVNRT is the next one, but again, not really much of that in the neonates, you don't need to worry about. And then we move on to AVRT. Oh, excuse me. And so AVRT is an atrioventricular reentrant tachycardia with the accessory pathway. So Wolff, Parkinson, White, which I'm sure you've all heard of, would be a part of AVRT. Now, it feels like this is coming to the end where we've actually got the majority of our tachycardias are AVRT in this age group. 70% of all tachycardias in this kind of age group are going to be this orthodromic AVRT. But I'm not going to spend too long on it because Dr. McCanta coming straight after me is going to be talking all about that in a second. But I'm just going to focus on a couple of things for the relevance of this in children. So in the neonate, we are looking at tachycardia, which is mediated via this accessory pathway. So we see the conduction come down over the AV node, round and back up again around that accessory pathway. And so it's going round in a circle, but because it's using the same conduction system as normal conduction, it is a narrow complex tachycardia. And so when we look at the tachycardia itself, it can be very fast, up to 300 beats per minute, narrow complex. And then when we really zoom in, often we will see a little P wave on the back, a backwards P wave because it's coming from low to high and showing us atrial activation. And again, what are we going to do? We want to block the AV node. So the final thing I just want to talk about was vagal maneuvers. And there are lots of different ways of doing it. And some will take this really quite mean approach of dipping a poor baby in a bucket of ice water. I was taught 5 to 30 seconds. 5 seconds feels like a lifetime. 30 seconds is longer than my nerve will normally take me, but it can be highly effective. When it's not effective, adenosine again. So adenosine we've just talked about, and you can go back. And so we end up often with this termination, a QRS, termination in the A, and then a stop. What if it starts again though? And that can happen, and that can be really quite anxiety inducing for everyone, that you feel that you failed. You haven't failed, you've stopped the tachycardia, but you need some kind of pharmacology, and beta blockade is often enough, but flecainide and amiodarone can be more effective. So that's my time up, I think. So we've talked about a whole range of different things. There are all that sort of smorgasbord of different arrhythmias, but I think the take-home points: bradycardias in the neonates is going to be congenital complete heart block for the most significant and the most common. And then tachycardias, AVRT is the commonest, and you're going to hear lots more about that in just a moment. But bear in mind atrial flutter, the miracle arrhythmia in neonates. I still do not understand why neonates get it, and then once you're more than a month old, nobody does really until you're an adult again. And then ectopic atrial tachycardia as well. And on that, I will unshare my screen and take it away from there.
Thank you so much, Henry. That was a really comprehensive and beautiful and well-organized talk, and much appreciated. We do have one question. I know we talked about saving them to the end, but it would seem to make sense here to just clarify this real quick. And the question is, when we say SVT in neonates, is it AVRT or AVNRT that we're referring to?
A good question. So SVT is a funny kind of, I won't get on my soapbox here. When we say SVT, we're saying supraventricular tachycardia. That's what it means. It means above the ventricle. If you're being really pedantic, AVRT actually involves the ventricle as well. So it's not purely supraventricular, but we would very firmly put AVRT in that big, broad SVT basket. So SVT, though, is everything that comes from or includes above the ventricle. So everything I talked about there in the narrow complex group, we would put in that SVT basket. So that can be ectopic atrial tachycardia, atrial flutter, AVNRT, which, as I say, we don't see very much in neonates, but is still a type of SVT, and then AVRT with that accessory pathway. So they're all in that kind of SVT umbrella. But these, you should always think of them like Venn diagrams, that there's a bit of overlap here, that SVT is not a perfect category, and broad complex and narrow complex are not perfect, but they match pretty closely. If you think of narrow complex tachycardia and SVT as being roughly the same thing, then you won't go too far wrong.
Great, thank you for that, Henry. Speaking of SVT, our next speaker is my friend and colleague, Tony McCanta. Tony splits his time between the Children's Hospital of Orange County and up here in Los Angeles at Cedars Sinai Medical Center. And Dr. McCanta is going to be speaking to us this morning about pediatric SVT. Go ahead, Tony. You're muted.
All right, thanks for having me, and thanks for everyone who's been involved with this. Let's see, can you all see my screen?
Yeah, it's not in presentation mode though, if you could, but we do see it though.
Okay. Is
Perfect.
that okay?
Perfect.
There we go. All right. Well, let's start off with a case. This is a 12-year-old previously healthy girl. She was swimming at swim practice and had abrupt onset of tachycardia. The thing she really noticed is after she was done swimming, for the next hour, she continued to have this feeling of palpitations. She had no chest pain, no shortness of breath, no real dizziness. Her mother did note that they could see beating in her neck. And so they brought her into an emergency room, and this was her ECG. And what you can notice is a narrow complex tachycardia, like what Dr. Chubb just went over. And really, I would say we can't really see P waves. Some of us, might look in the beginning of the T wave or right after the QRS for P waves, but I would just say we can't really see P waves. Her rate is about 150 to 160 beats per minute. And so her diagnosis is supraventricular tachycardia. We, at this point, can't really tell the mechanism, and to be honest, it doesn't necessarily matter at this point. But what would you think her next step in management would be? So you can instruct the patient in vagal maneuvers. You can start an IV and give adenosine. You can consider direct current cardioversion, or you can start amiodarone. So just think about that as we get going here about what you do for this 12-year-old previously healthy young woman. So again, her diagnosis is supraventricular tachycardia. In pediatric age group, it happens in about 1 in 500 children. So it's actually fairly common when you consider your surrounding area and the number of kids that are in that area. As you can see here, there's an abrupt onset to the tachycardia, and often people will also describe an abrupt termination as well. The symptoms are palpitations, dizziness, chest pain, very, very rarely syncope, but for the most part, it's abrupt onset palpitations. The natural history and distribution, SVT really has kind of a bimodal distribution. You have the fetal and neonatal presentation, like what Dr. Chubb just spoke of. And then you have a presentation kind of late childhood, early adolescence, anywhere between maybe 9 and 13 years of age. And why is that? Why is there this bimodal distribution? You know, the short answer is nobody really knows. The longer answer is that there may be some changes in autonomic tone. There may be some changes in atrial anatomy or AV nodal anatomy. And then we'll go over in a little bit, there are some changes in the actual mechanisms. Generally, SVT is non-life-threatening. And honestly, this is one of the first things I say when I meet a family with SVT, and it, hopefully reassures them or calms their nerves that this is a non-life-threatening arrhythmia in somebody with a structurally normal heart. The only caveat is prolonged tachycardia greater than maybe 12 hours or perhaps even longer than that can cause a tachycardia-induced cardiomyopathy. And so you do want to treat these patients. And my general take home to families is if they're in it for 30 minutes or so, start packing your bags to go to an emergency room. If they're in it for more than an hour, definitely head on in. So the mechanisms of SVT. The most common mechanism of pediatric SVT is this orthodromic AV reentry, or what we call AVRT. And it involves normal conduction through the AV node and specialized conduction system, and then abnormal conduction up this accessory pathway, forming this reentrant loop. And so you can see here a patient in sinus rhythm has a P wave before the QRS. The same patient in SVT will have a QRS and then a P wave, an inverted P wave after the QRS. And that's, again, the sign of electrical activation going the opposite direction up this accessory pathway. These accessory pathways tend to exist before birth and exist throughout childhood. And it still is a very rare circumstance that will put somebody into SVT. And often they don't know that they have these accessory pathways until after they've been diagnosed with SVT. Second SVT mechanism that becomes more frequent in adolescents and certainly more in adults is AV node reentry. And what that involves is two pathways around the AV node. Almost all of us have a fast pathway, which is this upper way through the AV node. About a third of people, and maybe even more than that, and to be honest, we probably don't even know how many people, have a second AV nodal input that's lower, and it's called a slow pathway. And this can set up a reentrant circuit that if you block in your fast pathway, it can go up the slow pathway and turn around and come back the fast pathway. So it's reentry within the AV node and possibly involving the atrium as well. These patients do not tend to have clear retrograde P waves when they're in the typical kind of AV node reentry. Sometimes this kind of reentry can go around the opposite way, and they can have P waves and kind of a long, what we call long RP. does terminate with vagal events and adenosine. And that's why we say, it doesn't really matter the mechanism. When you first see a patient with this, it could be either AVNRT or AVRT. The other SVT mechanism is ectopic atrial tachycardia, and it's what we call long RP, meaning that if you have your R wave here, your next P wave is right before your next QRS. And so this can get confused with sinus rhythm, especially if you only have a single lead. But if you look at the leads, especially lead 2, like Dr. Chubb just described, you'll see that the P wave morphology is different than a sinus P wave. And these can be a little more dangerous at times because they can go unrecognized for longer periods of time. They may have slower rates, like 130s to 150s instead of the 200s to 220s. And that can lead to a tachycardia-induced cardiomyopathy. So I actually worry more about this causing a cardiomyopathy than I do about a 220 or 230 with no actual P waves. And then adenosine can terminate the tachycardia. It can also just block the AV node, and then you can actually see more P waves than QRSs here, so it can be diagnostic. Similarly, atrial flutter, like Dr. Chubb had just talked about, it can occur in children. It's much less likely. It usually involves re-entry around the tricuspid annulus. And the AV node is just kind of a passive bystander. So you can get, it'll conduct as fast as it will conduct, but if you block it with adenosine, you'll often see the sawtooth pattern. And so this is actually a classic paper from 1992. This looks at SVT mechanisms for age. And as you can see, AVRT, or accessory pathway mediated tachycardia, really is the bulk of tachycardia at birth and the first several years of life. And then AV node reentry is essentially doesn't happen at that time and slightly increases, and then by mid-childhood or early adolescence becomes slightly more likely. Atrial tachycardia kind of keeps its position here as being less than 20% or so of all tachycardias. And then as kids get older, so this is 5 to 10 years old and 11 to 20 years old, this is a different way of looking at the same graph, but you'll see that AV node reentry, this light pink, becomes nearly as likely as AVRT. And then atrial tachycardia, again, stays less likely, but becomes more likely over time. And so really when you have a kid between maybe 5 and 15 years of age, it really could be either AVRT or AVNRT, and you essentially treat these the same. So how do you treat them? Well, acute SVT treatment, if the patient's unstable, DC cardioversion is treatment of choice. If they are stable, which the majority will be, you can recommend vagal maneuvers or trivagal maneuvers, and then adenosine, as Dr. Chubb had talked about. If there's no effect to adenosine, you want to check your IV site or get larger bore access. You want to give it faster, and you can escalate the dose beyond the 200 micrograms per kilogram. And even you can go high in larger kids, 18 to 24 milligrams may be required to successfully block the AV node. And if you still have no effect, then you'll want to proceed with DC cardioversion or medications if the patient is still stable. If it's incessant, so again, if it blocks, but it immediately restarts, you need an antiarrhythmic drug, and then you can try either your vagal maneuver or your adenosine again. You do not need higher dose adenosine. If you've already blocked with adenosine, it's going to do the same thing. You can block it, but the tachycardia itself is going to go again. And similarly, you do not need to DC cardiovert. You can't beat the tachycardia out of these patients. If you've already blocked it, it's not a matter of blocking it again. It's a matter of preventing it from happening. Preventing it from happening is chronic SVT treatment. And so once you get your patient out of SVT, you'll want a controller medicine over time. And the most common are beta blocker medicines. If the digoxin is also very effective at slowing the AV node and altering autonomic function, so decreasing your tachycardias. And then calcium channel blockers are also used, especially in adults, certainly not in infants. And so I'd caution from using calcium channel blockers in infants, as it can affect their myocardial function. Second line agents, I really just broke them into kind of two broad categories, but they're sodium channel blockers, so flecainide or propafenone, and then class 3 agents, which prolong repolarization. And so the class 1 agents will slow your conduction. The class 3 agents will prolong your repolarization and often prolong your QT as well. So I'd start with first line and then work your way up if needed. Second line therapies can be proarrhythmic, so they're usually started in the hospital with monitoring. And amiodarone has major long-term side effects, so it can be used in the short term, but if it's all you have available, you have to use it. But if you can use anything else long-term, we prefer to use that. And then electrophysiology studying ablation is a effective and safe therapy. And so getting back to our first patient, our swimmer, we took her to the lab, the EP lab, and she actually had AV node reentry. So she had reentry around her AV node up a slow pathway and around her AV node. We mapped this area here and we applied radiofrequency to the slow pathway region, with the fast pathway being up here. And she had no further tachycardia, and she's been over a year out and ended up getting back to her swimming and being very successful at that. So just in our last few minutes, we'll talk about a sort of subset of SVT, and this would be a 10-year-old healthy boy who's had palpitations at rest multiple times. But when we saw him, he just had this ECG. And as you can see, there's a short PR interval. There's a delta wave occurring really right after the P wave. And so this is diagnostic for Wolff-Parkinson-White syndrome. And Wolff-Parkinson-White syndrome is an antegrade conducting accessory pathway. So SVT is through a retrograde conducting accessory pathway. Well, pathways can go both antegrade and retrograde. In sinus rhythm, you go down your AV node and also down your pathway. If they have a PAC or something that blocks their pathway, they'll go down the AV node and turn around and come back up the pathway and have a narrow complex tachycardia. And then they can also go around the opposite way and have an antidromic tachycardia. The risk of SVT is still non-life-threatening, but these patients have increased risk of sudden death due to pre-excited atrial fibrillation. And so if you have atrial fib, it can conduct and become ventricular fibrillation. And so now atrial fibrillation is very uncommon in children, but this can still increase a patient's risk of sudden death or having sudden cardiac events. And so with Wolff-Parkinson-White syndrome, if they're symptomatic, the recommendation is to assess and treat. When available, an invasive EP study and ablation is a treatment of choice. If asymptomatic, there's still a potential for sudden cardiac arrest, and it's nearly impossible to non-invasively risk stratify these patients. Previously, they'd recommended doing exercise testing or ambulatory monitoring, and if you see the accessory pathway go away, you can consider these patients less risk. But many new papers now have come out that said that people who have had events, many of whom, loss of pre-excitation does not predict or does not clear you from the possibility of sudden death. And so actually Dr. Chubb and his colleagues had kind of revised a recommendation for how to non-invasively risk stratify these people. And ultimately it leads to that they should have EP study and ablation. But what if you don't have access to EP study and ablation? Well, you still would treat with beta blockers. You could consider sodium channel blockers, which can work on the pathway, which the pathway itself is myocardial, and so it can slow conduction through the pathway. And the drug to avoid would be digoxin. And so this is just in our last maybe a minute here, example of ablation of WPW. You can see this wide complex rhythm, sinus rhythm with wide complex. And when you ablate it, instantaneously it goes to a narrow complex. This is what it looks like inside the heart. You can see electrical atrial activation and ventricular activation going to separate atrial and ventricular activation. And so in summary, pediatric SVT is common and generally not non-life-threatening. Acute SVT management involves vagal maneuvers, SVT administration, and DC cardioversion. Chronic SVT treatment includes oral medications. When available, EP study and ablation is safe and effective. It has low chance of recurrence for most SVT substrates. And Wolff-Parkinson-White syndrome has the potential for life-threatening ventricular arrhythmias and sudden cardiac death, and therefore aggressive management with medications or with EP study and ablation when available is recommended. And that's all of SVT in 15 minutes, or a little longer. I apologize.
Tony, thank you very much for a really thorough and great talk. We gave you a hard task of trying to cover that much in only 15 minutes, so you knocked it out of the park. Thank you very much. There are some questions rolling in. We're going to save some of these for the end because they could lead, I think, to a nice discussion at the end as well. And so hang on to the questions and we'll get to them soon. I'm going to move on to our next speaker. It gives me great pleasure to introduce one of my colleagues here, Mark Shwayder at Children's Hospital Los Angeles. And we've asked him to talk about pediatric post-operative arrhythmias. Dr. Shwayder, please take it away.
All right, great. Can you see my screen? Yeah.
Yeah, we can see it perfectly.
Fantastic, thank you. All right, well, thanks very much for having me. It's a pleasure to be here. And unlike Dr. McCanta, they gave me post-op arrhythmias, and I was like, that's too much. So I'm just going to do junctional ectopic tachycardia in 15 minutes. So here we go. I have no disclosures. So we'll start with a case. We have a 12-month-old who presents with a murmur, and he's falling off his growth curve. And so an echocardiogram is obtained, and he's found to have tetralogy of flow with a moderate-sized BSD. He's repaired in the operating room with a smooth course and comes back to the ICU in sinus rhythm. During his first post-operative night in the ICU, he becomes progressively more tachycardic. His blood pressure is dropping, so epinephrine is started, and EKG is obtained that shows this tachycardia. So the question is, what do we do? And so that's what we're going to talk about for the next 15 minutes. So the big picture in my mind for junctional ectopic tachycardia is that it's a common post-operative arrhythmia in surgery for congenital heart disease. It's self-limited, it will go away, but it can have significant hemodynamic consequences while it's going on. And then management really just involves slowing the jet rate to allow for overdrive pacing to restore AV synchrony. So those are really the big, like the take-home points from this talk. So Dr. Chubb already mentioned this. I'm just going to go into, again, a little bit more detail. So junctional ectopic tachycardia, it's an automatic arrhythmia. So it comes from this area of the, oh, you can't see my pointer, hold on. Okay, so it comes from this area here of the AV node and the HIF, and it causes a narrow complex tachycardia. That's in quotation marks because the way I think about it, just like Dr. Chubb said, is if you have a reason to have a wide complex tachycardia at baseline, or a wide complex QRS, at baseline, in other words, you have a bundle branch block, any of your narrow complex tachycardias could appear wide complex. So if, especially in tetralogy of flow repair, you often get a bundle branch block. So your junctional ectopic tachycardia might look narrow like this, but it could look wide. So it should look the same as your baseline QRS. The rate is quite variable. If the rate doesn't actually reach tachycardia for age, we would call it an accelerated junctional rhythm. Usually for papers doing research on this, it has to be greater than 100 beats per minute for adults or 95th percentile for in children to be called junctional ectopic tachycardia. I have been taught even it has to have hemodynamic compromise. We're not that strict here about that. But how would it cause hemodynamic compromise? Well, the signal to beat's coming from the middle of the heart. And as Dr. Chubb already mentioned, it's going to go down using the normal conduction system. So it'll be narrow if you have a narrow QRS at baseline. And then it may or may not go back up to the atrium. So if it doesn't, we call that VA dissociated. But either way, if it's at the same time or doesn't go backwards, you lose the synchrony between the atria and the ventricles. Now, that, depending on your substrate on your heart, that could be a small problem and a sort of minor inconvenience, or it could be a major hemodynamic problem. And it's quite variable. So in one study of 89 kids who had JET following congenital heart disease surgery, nearly 40% of them had episodes that weren't hemodynamically significant. So there's definitely quite a range here. If you look up JET in the textbook, it is usually VA dissociated, but I would say, especially if you're doing surgery on younger children, you'll often see one-to-one retrograde conduction. So in this study in 2010, they found actually only 50% of their pediatric patients had VA dissociation. The other 50% had one-to-one retrograde conduction. So how common is this? It's pretty common. Incidence vary depending on the paper, but somewhere sort of 5 to 15%. And it does seem to be highest when the surgery involves VSD closure and or sort of RVOT muscle bundle resection, like you might get in tetralogy of Fallot repair. In this study from 2002, they had an incidence, if you just look at the tetralogy repair, of nearly 25%. So it certainly makes sense that if you're repairing a VSD and your conduction system is running right along here, that sutures in this area might either cause hemorrhage that can infiltrate into the conduction system, which is what we're showing here. So this is a histology slide of the left bundle branch block with hemorrhage, and you can imagine that this is really irritating and causes a lot of ectopy. Interestingly, though, it definitely can occur when surgery is not right in the crux of the heart. So it's well described in TAPVR, or total anomalous pulmonary venous return repair, or partial anomalous pulmonary venous return repair. I would say we see it not uncommonly in single ventricles where you don't even go inside the heart. So in a single ventricle where you just put a BTT shunt in, or you have a stage 1 and you just do the Glenn, those patients definitely can get JET, and you can get it in cardiac transplant. So there is some direct mechanical trauma that can happen and cause JET, but there also has to be sort of an inflammation, maybe relative ischemia mechanism as well. It tends to show up in the first 24 hours post-op. There's a little bit of a range, and the average length is actually pretty short, only a couple of days. And again, there's a range there, sort of 0 to 7 days, plus or minus. So how do we diagnose this? It's easiest to make a diagnosis with an EKG, and using the atrial wires that your patients come out of the OR with can be especially helpful. So the wires that are directly attached to the atrium, when they come out to the skin, instead of plugging them in to be used in the temporary pacemakers, you can unplug it from this connector here and plug this directly into your EKG machine, and then you can get a signal reading from directly on the heart. And so there are actually a couple of different ways of doing this, so I just wanted to at least show you one specific way of doing this. So this is how we do it here. So you connect the right leg and left leg to the baby just like normal. And then the right arm and the left arm, the alligator clips that would go to the stickers, you take them off the stickers, and you clamp them directly onto the wires coming out from the atrium. And so what that gives you is a bipolar electrogram. So what lead 1 used to be is now purely looking at the electricity in the atrium. Okay? So if we go back to our case, this is the rhythm he was presenting in. First of all, it would be nice to know if this was his usual complex, right? Because that will change things for us. We, as routine here, get an EKG and atrial study on all patients as soon as they come back from the OR. Part of this is to assess what the rhythm is when they show up in your ICU, but also to establish a baseline. So I will tell you, this is his baseline QRS complex. It's just faster. Now, the electrophysiologist might say, oh, I can see P waves. There are a couple here, but it's pretty tough, and I don't see really much over here. So if we hook them to the atrial electrogram, what we see is these very sharp signals every time the atrium depolarizes. So you still see your QRS, but now you see these sharp atrial electrograms moving through. And so there are more QRS complexes than atrial electrograms. So this is a VA-dissociated junctional ectopic tachycardia. Just to show you a few more examples, not everyone sets up their atrial electrograms with lead 1. A different way of doing it would be to put the limb leads on as normal and then just take the V1 alligator clip off and attach the V1 alligator clip to the atrial wires, and then it would look like this, where your limb leads look normal, but when you look at the rhythm strip that has your V1, you can see these sharp spikes moving through, and that sort of helps you identify. You can see that if we start here, that the QRSs are actually going faster than the P waves. So there are more QRSs than P's here, and so that helps us make our diagnosis. And notice again, this is probably a post-op TET. We have bundle branch block. This is still not a ventricular arrhythmia. And just because I wanted to be complete, I want to show you this is what it would look like with one-to-one retrograde conduction. You can see without an atrial lead, it's pretty hard to make any decisions about the P wave to really figure out where that is. But once you get the V1 hooked up to the atrial wires, you can see the sharp spike. And so this is a one-to-one conducting jet. Okay, so you've made the diagnosis. What do you do? Really what we need to do is just support the patient while you allow the jet to run its course. Now again, some of the time jet's going to be asymptomatic, and some of the time it's going to be very symptomatic. So it sort of sounds easy to support the patient while you let it run its course, but it can be quite challenging. And so we're going to achieve this by doing two things. So we're going to decrease the rate of the jet, and we're going to provide AV synchrony. All right? So there are a lot of things we can do to decrease the jet rate. So we want to decrease the catecholamine input. So if possible, try to reduce infusions of catecholamines. We don't tend to use epinephrine for no reason. So usually it's hard to wean off of those if you're needing them. But if it is a situation where the ventricular function is okay and you might be okay with vasopressin as opposed to epinephrine and norepi, that might actually help. It's important to maintain sort of high normal levels of your electrolytes and a normal pH. And then we're going to spend some more slides talking about how to slow the jet automaticity and how to provide AV synchrony. So first thing in slowing the jet automaticity is to actually cool the patient down. Now, there are two ways you can do this, and I have been at places that have done both. So you can actively cool the patient where you use ice packs or even a cooling blanket, and you try to get them quite cool, so 32 to 34 degrees Celsius. We have good data that shows that slows the jet rate, so that it works well. That's the pro of using this approach. But the con is that when you get that cold, you're going to have shivering. To decrease metabolic demand, you're going to need to use paralysis, so you have to be intubated. And you also get with this the sort of comorbidities that come with cooling, so they're coagulopathies and et cetera. So this works well, and if you don't have access to some of the medicines that we're going to talk to, this is definitely something to consider, but it comes with cons. And also on there, because you have to be intubated, it definitely prolongs intubation times and ICU stays. So what we do here is more passive cooling. So our approach is more to aggressively treat fever, so don't let them be febrile, and then just unbundle them and sort of let their body temperature reach between 35 and 36. So that's our approach to slowing here. But again, if you don't have the medicines available and you're in serious hemodynamic trouble, active cooling could help a lot. There are a lot of different medications that you can use to slow the automaticity. So what you choose obviously will depend upon availability. I'm going to talk about two of the most commonly used drugs, but there are different ones and more drugs. So the first one is dexmedetomidine. This is a centrally acting alpha-2 agonist. So it decreases sympathetic output, it causes sedation. It does have antiarrhythmic properties. It changes various things that we can measure in the EP lab in terms of how fast electricity moves through the heart. The dexmedetomidine dose, somewhere between 0.2 and 1.5 mics per kilo per hour. This is just my personal opinion about dexmedetomidine. I think for these post-operative patients, they need to be sedated anyway, and since it's a good drug for sedation, I like to use dexmedetomidine. It is not a magic bullet. It's not going to mean you never need anything else, but I do like to use it, so I encourage you. If it's easily available, I think it's a good drug to choose for sedation. Now, if you try that and it doesn't work, the most commonly used antiarrhythmic for post-operative jet is amiodarone. Dr. Chubb already talked about, and Dr. McCanta talked about this drug class, but it's very effective in slowing automaticity and even can restore sinus rhythm. The usual bolus dose for amiodarone is 5 milligrams per kilogram over 60 minutes. You can give it faster, but the faster you give it, the more it's associated with hypotension. So if you start giving it and your blood pressure really starts dropping, just slow the infusion rate. Some places like where we are here, we do actually divide it. Instead of 5 mg per kg, we give it in 1 milligram per kilogram aliquots just to watch for effect, but it's more or less the same thing. And then the drip rate, you can start at 0.5 micrograms per kilogram per minute. So cooling medications, that's what we're going to do to slow the jet rate. And then remember why this is so hemodynamically significant is because of the loss of AV synchrony. So if you've done those maneuvers and sinus rhythm has been restored, fantastic, nothing more to do. If not, though, and what I would say seems to happen most commonly is that you slow the jet rate, but they're still in jet. So now you want to provide AV synchrony, and to do that, you just pace. So in general, you just need to pace sort of 5 to 10 beats per minute faster than the current jet rate. Why didn't we do this just right off the bat? Well, we might have to slow the jet quite a bit before we can sort of pace above it at a rate that the patient's going to tolerate. So if your jet rate's 200, technically you could pace at 210 and provide AV synchrony, sort of suppress the jet, but that's so fast that you're not going to have much filling time, and it's unlikely the baby's going to overall do better at that rate. So we use the things we talked about to slow the rate so that we can pace above it at a rate that will be acceptable. Okay? The jet rate is going to change over time, so it may speed up that first day. So if you're pacing at 150 over it, you don't be surprised if 6 hours later you're going to have to go at 160, and then it sort of comes and goes. That's normal. It's an automatic rhythm that fluctuates like that. And remember that the jet can happen both with mechanical trauma, but also just sort of on the scale of inflammation. And I always teach my fellows that it can be on a spectrum with heart block. So a lot of inflammation in the AV nodal area can start by causing jet and progress to third-degree heart block. So just don't forget, you may need to pace both the atrium and the ventricles using DDD pacing. So in our case, so this is the electrogram for our case. We made the diagnosis with this atrial wire study. We passively cooled him to 35.5. we started dexmedetomidine at 0.4, but we couldn't wean the epinephrine because his blood pressures were too low. He was still in jet, so we up-titrated the dexmedetomidine. His jet rate was still 190 to 200. So we gave amiodarone 5 milligrams per kilogram over an hour, and that helped reduce the jet rate to 150. We were able to AAI pace him at 160, restoring AV synchrony. His blood pressure improved, and we were able to wean down the epi, and the jet resolved by post-op day 4. So thank you guys very much, and I'll be happy to answer your questions at the end of the session.
Thank you, Mark, for another great talk. We are, again, going to take all our questions at the end at this point, so please feel free to post them in the Q&A section, and we will not forget them. We will get to them, I promise. So we're going to move on now to the next talk, and again, it's a great honor and privilege to introduce another one of my colleagues, Allison Hill, who's going to talk to us about heart block, ranging from infancy, childhood, and as well as in the post-operative period. So please, Allison, take it away. We see your slides really nicely.
Great, thank you. Thanks for having me. I'm looking forward to this. I appreciate the opportunity to chat with you guys. So I'm going to be talking about heart block in infancy, childhood, and the post-operative period. And I find this actually really fascinating, just to think that there can be a child with heart block who's critically ill because of it, and then there can be another child with heart block who's perfectly seemingly fine and asymptomatic. So I find it particularly fascinating, and I really am looking forward to sharing some thoughts with you. Let's see here. Here are my disclosures. So to start, I'd like to briefly review the types of heart block before diving into a case and then exploring the different etiologies and how to handle the workup and management of a patient who presents with heart block. Dr. Chubb did a really nice job of explaining sinus rhythm, so I'm going to skip that and instead just go straight to what heart block is, which is a delay or an interruption in the transmission of an impulse from the atria to the ventricles. And this can happen at the level of the AV node or beyond that at the His-Purkinje system. There are 3 different degrees of heart block, first and second, which is then divided up into Mobitz 1 and Mobitz 2, and then third degree. In first degree heart block, there's prolongation of the PR interval due to slowing at the AV node. As you can see here, if we look up closely on that EKG from a patient of ours here, the P waves march out, but they're somewhat hidden in the end of the T waves. The PR interval is beyond the upper limit of normal, which is typically thought to be 200 milliseconds or 1 big box on the EKG paper, although there are age-related norms, so it can be expected to be a bit shorter in infants. In second degree AV block, ultimately, that implies that there are dropped beats, meaning that there are some atrial beats that are not conducted to the ventricle. The first type of second degree block is Mobitz 1 or Wenke block, which means that there's a progressive lengthening of the PR interval before a beat drops. Again, this is due to an abnormal AV node, typically, although it can be entirely benign. If we look up closely at this example, the P waves march out and cause progressive PR prolongation before we see a dropped beat. And now we're going to be moving on to kind of the higher degrees of heart block and the more concerning types. So Mobitz 2 is the second type of second degree heart block. And this is when there's a normal PR interval that's constant, like I said, normal in terms of its duration, and either each atrial beat or P wave either conducts or it doesn't. It's kind of an all or nothing response. And this is a sign of His-Purkinje disease and often results in an irregular rhythm. If we look up closely again at this example, we can see the P waves marching out with a constant PR interval prior to a dropped beat. Third degree block or heart block, which is the same as complete heart block, is when there's complete dissociation of the P's and the QRS's. So they're just beating independently. And this EKG shows nearly complete heart block. This does typically result in a regular ventricular rhythm, meaning typically kind of a constant rate without much variability, although that's not always the case. So now that we've reviewed the definition and types of AV block, I think I'd like to just go through a case. So I take care of a little girl who first presented as a fetus, actually at 25 weeks, due to bradycardia. Her mother was entirely healthy and had previously had a healthy child. A fetal echo showed complete heart block. There are several ways of viewing complete heart block on fetal echo, but if we focus our attention to the upper left of the screen here, we can just see that the A's and the V's are beating independent of one another, and the ventricular rate is slow. The cause of fetal heart block is actually surprisingly uniform. When an infant is born with heart block, 95% of the time, it's due to transplacental passage of maternal anti-Rho or anti-Law autoantibodies. So my patient's mother actually tested positive for the anti-Rho autoantibodies. And these autoantibodies cross the placenta, bind to the fetal cardiomyocytes, ultimately cause apoptosis, and then cause inflammation and fibrosis along the fetal conduction system. And this results in fetal heart block that typically develops in the second trimester, just like we saw it in my patient. Over the course of the pregnancy of this patient, we did serial fetal echoes, and luckily the fetal heart rate remained stable at about 47 beats per minute. Moderate ventricular dilation developed, but the function actually remained normal. There was a small pericardial effusion by the time the infant or the fetus reached the third trimester, but no hydrops was seen, so no other effusions were seen. Ultimately, the infant was born at 33 weeks gestation, weighing 1.2 kilograms. Postnatally, the heart rate was 40, but actually surprisingly, she was able to maintain a normal blood pressure and had normal premature neonatal behavior and problems, and wasn't kind of out of the realm of expected neonatal issues for a 33 week 1.2 kilogram infant. This was the postnatal EKG, and as you can see, if we look up closely at the rhythm strip, there's complete heart block. These are the P waves marching along here with this very slow ventricular rhythm here. Despite this heart rate, because the infant was doing well, we had to ask ourselves really what the best approach was for this infant. And so to think that through together, we'll have to think about what the risks of the situation is, namely, what are the risks of a neonate with complete heart block? There are ultimately two main risks for infants with congenital complete heart block. Without pacing, there's a significant risk of mortality. This graph is from a paper from a national lupus registry that ultimately showed the mortality risk at different ages for patients born with congenital complete heart block. You can see that there's significant risk in the fetal period, as well as in the early neonatal or early infancy period. And then there is some continued risk of mortality thereafter, although it becomes somewhat less likely. And the overall mortality for infants or children born with congenital complete heart block is about 19%. There's also a significant risk of developing cardiomyopathy, regardless of whether a pacemaker is implanted. So somehow we think that these autoantibodies cause a reaction in the cardiomyocytes outside the conduction system as well. There was a multi-center international study that ultimately demonstrated in this graph the percentage of congenital complete heart block patients who did not have cardiomyopathy declined over time. And the overall rate of developing a cardiomyopathy in patients with congenital complete heart block was about 10% during childhood. So ultimately, based on the mortality risk, as well as the degree of bradycardia in this patient, a decision was made to implant a pacemaker.
This is great, actually. This is one we can't do mission.
So as you can see here, there's a ventricular lead that was placed on the RV close to the apex, and then we have the generator in the infant's abdomen. And just to put this all into size perspective, this is a 1.2 kilogram infant. So while this battery pack or generator appears enormous compared to the infant, it's not much bigger than an American quarter coin. We have done surveillance echoes over the last 3 years, and there's been normalization of the ventricular size, and there continues to be normal ventricular function. So while this case demonstrates the course of a patient with the most common cause of neonatal heart block, the reality is that outside of infancy, the child who presents with heart block that may not have been there since infancy could have a really large variety of etiologies. So the way that I like to think about the causes of heart block is to divide it into those that are reversible or possibly reversible versus those that are irreversible, since that really impacts the treatment drastically. So reversible causes include cardiac surgery or catheterization early on, high vagal tone, meaning even an athlete or a very well-trained teenager, particularly during sleep, could have low grades of heart block, so first degree or Wenckebach, and that could actually be entirely normal and reversible. Other causes of reversible or possibly reversible heart block or myocarditis, including COVID-19, Lyme, rheumatic carditis, hypothyroidism, medications such as digoxin, beta blockade, or calcium channel blockers, electrolyte issues such as hypokalemia. And then in terms of irreversible causes, like the case that we just discussed, immune-mediated typically is thought of as an irreversible cause of heart block. Late after an injury related to cardiac surgery, structural heart disease, such as LTGA or left atrial isomerism, can all cause permanent heart block. And there are also some genetic or inherited conditions, such as mutations in NKX 2.5, SCN5A, or TBX5, that can cause an autosomal dominant pattern of inherited progressive cardiac conduction disease. Certain types of cardiomyopathies can predispose patients to irreversible heart block. And then there's a subset of the population with heart block that we really just never know why they developed it. So the list of potential causes of AV block is long. And because it's so difficult to immediately identify the cause of heart block, I really focus ultimately on identifying any reversible causes. So when I first encounter a patient with heart block, I pay particular attention in history and physical to see if there are any components consistent with a recent infection, an overdose of medication, or symptoms related to thyroid disease or recent cardiac surgery. Obviously, an EKG can help define the degree of AV block. An echo can show us whether there's an anatomic problem or functional problem. Labs are helpful. And in the asymptomatic patient, ambulatory rhythm monitoring can be particularly helpful. With that workup, the first step in management is to use medication or temporary pacing to achieve hemodynamic stability in those who are unstable. And with the patient stabilized, we have time to address any reversible causes of heart block. I want to focus just for a minute on patients who've had a recent cardiac surgery to really define how long we should wait for recovery of AV nodal function and how likely that is to happen. So the literature on post-operative heart block in children has shown that approximately 3% of pediatric cardiac surgery patients develop post-operative heart block, and 2/3 of those with heart block recover AV nodal function. The question is, how long does it take? And in this study, this shows the percentage of patients with heart block that continues postoperatively over time. And ultimately, of those that recover function, 95% of them recover function within 10 days. So we typically wait about 7 to 10 days before implanting a permanent pacemaker when there's postoperative heart block. Outside of the postoperative setting, deciding which patients need permanent pacing and when is not entirely straightforward. But ultimately, in patients with an irreversible cause of heart block, we generally implant a permanent pacemaker in those with Mobitz 2, or those with complete heart block who are symptomatic or asymptomatic with high-risk characteristics, such as a wide complex QRS escape, complex ventricular ectopy, meaning lots of PVCs or VT, ventricular dysfunction, or with severe bradycardia. So while placing a pacemaker doesn't mean it's kind of the end of taking care of a patient with complete heart block, our time is up. So I'll sum up by reviewing 3 take-home points about heart block. The first is that heart block in neonates is generally due to autoantibodies. The second is heart block in children can be due to a large variety of causes. And lastly, management of heart block centers on reversing reversible causes and permanent pacing in those who have irreversible high-grade heart block who are symptomatic or asymptomatic with high-risk characteristics. These are some references. Thank you.
Allison, thank you again. That was great talk and a great summary of complete heart block. from little babies all the way to older patients. So thank you for that. Again, some good questions are getting posted. We'll save them for the end. I'm going to introduce our last speaker, who is a close friend who I miss dearly, Anna Kamp, out in Columbus, Ohio at Nationwide Children's. And she's going to talk to us about common arrhythmias associated with adults who are living with congenital heart disease. Anna, it's all yours.
Okay. Am I showing you the right? I think I need to switch this. Do you have the right screen now?
That looks perfect.
Perfect. Okay. Well, thank you so much. It's really a pleasure to be able to participate in this symposium today. And I will be talking about arrhythmias in adults with congenital heart disease. Initially, I'm going to focus on factors that can contribute to arrhythmias in adults with congenital heart disease, and then review tachy and bradyarrhythmias that are seen most commonly. And then just a brief overview of lesions that are at risk for arrhythmic sudden death. I purposely have avoided speaking about emerging technologies that may not be available to some on this symposium, and instead really want to focus on recognition of the arrhythmias. So arrhythmias are a major contributor to morbidity and mortality in the adult congenital population, and it's well demonstrated that the prevalence of different arrhythmias and various forms of ACHD increases with age. Arrhythmias are the most frequent reason for hospital admission in adults with congenital heart disease, and they are a leading cause of death behind heart failure for this population. There are many anatomic and hemodynamic factors that can contribute to the development of arrhythmias in adults with congenital heart disease, both pre-operatively and post-operatively. And I really like this figure from a prior review of arrhythmias in adult congenital patients. But in the preoperative state, we can see that sinus node dysfunction can be seen in heterotaxy patients or when the sinus node is displaced. AV node dysfunction can be seen in association with abnormal AV node location or abnormal function of the AV node. And then atrial tachyarrhythmias can result from atrial dilation due to AV valve regurgitation with increased pressure or volume loading. And similarly, ventricular tachycardias can occur due to aortic or pulmonary valve regurgitation with resultant increases in ventricular volume or pressure. Ventricular arrhythmias can also occur as a result of ischemia, myocardial hypertrophy, or dilation. Conversely, post-operatively, sinus node dysfunction can be seen due to fibrosis or evolving scar. Post-operative AV node block may occur as a result of a VSD patch or injury to an already dysfunctional and displaced AV node. Atriotomy incisions are a setup for scar-mediated reentrant tachycardia, and similarly, ventriculotomies are a setup for ventricular dysfunction and scar-mediated reentrant VT. Residual valve dysfunction, including AV valve regurgitation or stenosis, pulmonary or aortic valve regurgitation or stenosis can contribute to atrial ventricular dysrhythmias due similarly to the preoperative state of dilation and volume overloading. And then lastly, any manipulation of the coronary arteries could result in coronary injury and ischemia-related arrhythmias. Atrial tachyarrhythmias are common in the aging adult congenital population. It is estimated that 50% of adults with congenital heart disease will develop an atrial tachyarrhythmia, and that number is higher in some forms of congenital heart disease. The most common type of atrial arrhythmia seen in adults with congenital heart disease is intra-atrial reentrant tachycardia, commonly called IART, which is a macro reentrant atrial tachycardia, usually resulting from incisional scar or electrically diseased atrial tissue. Atrial fibrillation is also increasing with the aging congenital population. Management of atrial arrhythmias is multifactorial and may include antiarrhythmic therapy, atrial pacing, or ablation procedures. The diagnosis, however, is sometimes quite challenging, and even those patients who appear to be in sinus rhythm may actually be in an atrial arrhythmia. So this rhythm strip shown is of a 40-year-old Fontan patient and looks very consistent with sinus rhythm at the beginning of the tracing with first-degree AV block. However, when adenosine is given, you actually can see the P waves marching through very low voltage due to the atrial disease tissue, and confirming this to be an atrial arrhythmia. This table lists a summary of atrial arrhythmias encountered in common forms of congenital heart disease. And we can see that IART is commonly seen in many lesions, both after surgical repair, but also in unrepaired disease related to atrial dilation. In some of these lesions, such as detransposition of the great artery, status post-atrial switch, and Fontan palliation, rapidly conducted atrial arrhythmias may be poorly tolerated and could be a life-threatening arrhythmia. When we consider antiarrhythmic therapy for treatment of atrial arrhythmias, considerations towards systemic ventricular function as well as underlying sinus node disease must be made. This table depicts common types of congenital heart disease and the estimated prevalence of arrhythmias. And here you can see atrial arrhythmias may occur in as many as 50% of those with Epstein's anomaly, single ventricle physiology, and transposition status post-atrial switch. Conversely, atrial arrhythmias are much less common in other types of heart disease, such as transposition status post-arterial switch. The higher prevalence is in certain types of heart disease can certainly affect how we monitor these patients and how we evaluate them in acute care settings. Similarly, there are specific lesions with a higher prevalence for ventricular arrhythmias, specifically repaired tetralogy of Fallot and transposition with atrial switch. And this may guide surveillance testing and evaluation of these patients. I previously mentioned that atrial arrhythmias can sometimes be difficult to diagnose, and so one really must look carefully at the EKGs. This EKG is from an annual clinic visit of a 43-year-old man with repaired tetralogy of Fallot. He had no symptoms. Here, his heart rate is 90 beats per minute with the characteristic right bundle branch block of a patient with repaired tetralogy of Fallot. It would be easy to look at this EKG and see P waves before the QRSs and determine it to be sinus rhythm. However, when you look more closely at the P wave morphology, the negative deflection in the inferior leads is not consistent with sinus rhythm. Additionally, the right-sided leads demonstrate the atrial flutter waves quite nicely that were not easily seen in the other leads. This makes the point that atrial arrhythmias don't always present with rapid ventricular conduction, and a normal ventricular rate does not exclude an atrial arrhythmia. It also highlights the use of the right atrial leads, or the right-sided leads, which can help to discern the atrial activity. And when we look back at this patient's baseline EKG from prior visits, his EKG demonstrates sinus rhythm at a much slower rate. This makes the point that it's important to review prior EKGs in evaluating an adult with congenital heart disease, as atrial arrhythmias don't always present with symptoms of palpitations and the ventricular rates. This figure illustrates recommended antiarrhythmic therapy for adults with congenital heart disease and atrial arrhythmias. Catheter ablation may not be a consideration in many places, and antiarrhythmic therapy may be the best option for many patients. Medication recommendations are made based on the complexity of congenital heart disease and ventricular function. For complex heart disease, regardless of ventricular function, best evidence is the use of a class 3 antiarrhythmic medication. However, as you look through the figure, you can see that even in simple forms of congenital heart disease, if there is significant ventricular dysfunction, amiodarone may be the best option for medical therapy. Moving on to bradyarrhythmias, there are lesions which are known to have higher prevalence of sinus node disease. Heterotaxy with left isomerism has a high association with sinus node disease. But in the postoperative setting, those lesions with extensive atrial baffling or scar are associated with a high prevalence of postoperative sinus node disease, such as single ventricle palliation and transposition status post-atrial switch. How we treat sinus node dysfunction depends on patient symptoms and anatomy. The rhythm strip shown here is from a 37-year-old man with transposition status post-atrial switch procedure. He has sinus pauses demonstrated during overnight hours, some of which are quite prolonged, though he remains asymptomatic, and there's not an urgent need for permanent pacing in this patient. This EKG is from a 22-year-old woman with hypoplastic left heart syndrome and Fontan palliation at a biannual clinic visit who reports to be asymptomatic. This demonstrates sinus node dysfunction, and that when you look through the rhythm strip here at the bottom of the EKG, you really see no sinus activity that precedes the QRS. Instead, you see a junctional beat and a retrograde P wave that then conducts back down the AV node to give another ventricular beat. So in this patient with really no sinus node function, she is asymptomatic and her ventricular function is fine, and there is no indication for pacing. However, her ECG 1 year later with symptoms of fatigue is very different and demonstrates a ventricular escape rhythm with a ventricular rate of around 35 beats per minute. In this current situation, she now has symptomatic sinus node disease and a very slow escape rate, which warrants urgent pacing. This ECG is another example of a similar patient with double inlet left ventricle status postlateral tunnel Fontan and sinus node disease. He's in a clinic visit, asymptomatic, and his resting heart rate is 45 beats per minute. However, at his next clinic visit, his ventricular rate is 90 beats per minute. And while not tachycardic, is much faster than previously documented compared to his baseline sinus rate. In this ECG, the red arrows mark the P waves of his atrial arrhythmia, which are much easier to discern compared to other examples that I've shown you today. However, though the ventricular rate is normal, this patient was found to have new ventricular dysfunction at this time, demonstrating that sustained atrial arrhythmias can cause ventricular dysfunction even without ventricular tachycardia. His ventricular function recovered to normal approximately 6 months after cardioversion to restore sinus rhythm. In adults with repaired congenital heart disease, we often think of AV node dysfunction in two scenarios: those with congenital AV block or lesions with a high prevalence of the development of AV block, or those with postoperative AV block. In lesions associated with the development of AV block, such as corrected transposition of the great arteries, surveillance screening for AV node disease, such as with a Holter, is commonly performed. In repaired congenital heart disease, we see postoperative AV block most commonly in those with VSD patch closure, mitral valve surgery, or LV outflow tract surgery. We also see it in postoperative patients with displaced conduction systems, such as corrected transposition, in which the location of the AV node is less predictable and thus at higher risk of injury. AV node dysfunction may be intermittent, may occur over time, and not necessarily as an immediate result of postoperative AV block. This monitor tracing is from a 53-year-old woman with tetralogy of Fallot and atrial flutter with an implantable monitor. The monitor was placed about 2 years prior to this finding to monitor for asymptomatic atrial flutter. However, the above tracing demonstrates sinus rhythm with a rate of about 75 beats per minute and then abrupt high-grade AV block, a new finding for her. At follow-up EP studies, she was found to have significant AV node dysfunction, which was new at her age and warranted a pacemaker. I will briefly touch on sudden cardiac death in adults with congenital heart disease. The incidence of sudden arrhythmic death is estimated to be about 0.1% per year. However, in some subtypes of congenital heart disease, sudden arrhythmic death is the leading cause of sudden death. This graph from a study of sudden death in congenital heart disease patients shows lesions with high rates of sudden arrhythmic death, the most common including cyanotic Eisenmenger syndrome, congenitally corrected transposition, repaired tetralogy of Fallot, and left-sided outflow tract lesion. Clinical VT is thought to be a predictor of sudden cardiac death in many lesions, especially patients with repaired tetralogy of Fallot. This EKG is from a 28-year-old man with repaired tetralogy of Fallot who presented with palpitations, though hemodynamically stable, and demonstrates a wide complex tachycardia at about 170 beats per minute. His hemodynamic stability can often fool clinicians into thinking it must be SVT. However, the left bundle morphology of the wide complex tachycardia is suspicious for VT with a right ventricular origin. While he is hemodynamically stable, the concern is that this monomorphic VT will degenerate to polymorphic VT or VF and is likely a risk factor for him. So in summary, adults with congenital heart disease can have both atrial and ventricular arrhythmias, and the prevalence of arrhythmias varies based on specific congenital lesion. The prevalence of atrial arrhythmias can be quite high as patients age. However, the diagnosis of atrial arrhythmias may be challenging and should be considered due to the high prevalence of disease. Treatment of arrhythmias is variable based on age, congenital heart lesion, and comorbidities. Thank you very much.
Anna, thank you for that. What can be an entire symposium in itself, talking about adult congenital
Yes.
heart disease. I knew we gave you a big task to try to cover in 15 minutes. So thank you very much for that great overview. We have a number of good questions. So thanks for everyone's patience in addressing them. We're going to go back to the Q&A, and perhaps I'll ask Tony to answer this first, and then we can obviously then open it up to everybody and all the speakers to comment as well. But the question came from Esther Kamani, asking at what age should one consider EP studies for children on chronic meds for SVT, especially AVRT in particular? Tony, thoughts?
Yes, I mean, there's usually it's really size related. So 15 to 20 kilograms is kind of the low end that I use for elective ablations. But you know, the bigger, the better. So yeah, that ends up being right around maybe 4 or 5 years of age. At the same time, if the patient is well managed on medications, you know, we would love for them to be a little bit bigger. And that's my line in the sand. I'd be curious as to what my colleagues say as well.
Allison, Mark, is that a well accepted, or is there great variability institution to institution? Anna?
I think
I would agree. Go ahead, Allison.
we do the same thing. We use, I think 15 kilos is the cutoff for elective ablations, but I agree with Tony that the bigger the better at some point. I love to get the 8+-year-olds. It feels like those, yeah, the risks are much lower for those patients.
Yeah, and I think I would just add that it's not that we can't do it. You can do an EP ablation on an infant. It's just that the risks associated are very high. And if you look at the risks, as they get bigger, they really start to decline once they reach that sort of 15 kilogram range, which is why we're all quoting that as where we would choose an elective ablation.
It's very interesting because as interventionalists, I think we have a very similar cutoff for things like ASD closure. We can do them in smaller babies, but you know, these are generally elective. And if you can wait till bigger than 15 kilos, 20 kilos, the safety profile is much more favorable.
Just one thing that maybe Henry and I kind of didn't intersect on or sort of missed a little bit is just, you know, infants, fetuses and infants with SVT, a majority of them, it tends to get better or resolve completely by the first year of life, certainly even 6 months to a year. And so, you know, that's often we're just waiting that out, and then we trial them off of medications at either 6 months or 1 year. And so the majority of infants and or fetuses and infants will not need ablation. It's only people who have recurrences of SVT in their toddler years that, you know, may need that later on.
That's a really good point, and it's really your back's against the wall under a year. That it would be rare that you really feel that you have not been able to achieve any control, because you're trying to buy time more than anything. You're trying to get through to that 1 to 2 years, by which time a significant proportion have resolved spontaneously.
Thanks, Saul. There's another good question here, and maybe we'll direct it to Mark Shwayder. It's asking about what are the other, particularly in patients after congenital heart disease repair, surgical repair, what are some of the other common post-op arrhythmias to be thinking about after JET?
Sure. So I chose JET because I think it will be the most common hemodynamically significant arrhythmia that is different from something else you might otherwise see. You certainly can get the same kinds of arrhythmias that Dr. McCanta and Dr. Chubb were talking about. So you can get a flutter, you can get AVRT, a normal sort of orthodromic reciprocating tachycardia, the treatments for which are the same as they said. So adenosine might treat or diagnose the rhythm. If they're hemodynamically unstable, cardioversion. The only sort of nice trick you have in the post-op period of time is you have those atrial wires, so you can often use those to pace them out of rhythms if that's an option. The other significant post-op arrhythmia, heart block, is a big one that Dr. Hill talked about. And then if the ventricular function is quite poor, you definitely can see ventricular ectopy, non-sustained and even sustained ventricular tachycardia, for which I recommend amiodarone.
Oh,
Speaking
that's,
of amiodarone,
yeah, that's a perfect lead-in, Mark. Go ahead. If you want to read that question and answer those three questions, that would be great.
So someone asked, is there a need to do a loading dose? And when weaning off of amio, any need to change to an oral dose? And do you need to monitor thyroid function tests, and how often? Okay, so good question. So the loading dose part of the amio that we talked about was that 5 milligrams per kilogram. If you're really worried about your blood pressure, you can give smaller doses, like I said, 1 per kilo over longer periods of time. That's going to have less of an acute effect on your blood pressure. It's pretty rare that you're going to feel like you need amiodarone, but you can just start with a drip. So if you just start at 5 micrograms per kilogram per minute of a drip, you're not going to see that effect for a long time. And since you've already tried other things, by the time you get there, it's a pretty unusual situation. I think maybe I can think of one time where we started a drip without a loading dose. So it's pretty rare. Remember, for JET, we're just trying to support them as this rhythm resolves on its own. And since it's going to resolve in after a week, you really don't need an oral amio. A lot of times, in fact, we give the bolus dose, and that has an effect over 12 or 24 hours, and they don't even need a drip. They just get that bolus dose, and that's all that they really need. So you certainly don't need to transition to an oral dose, and since you're not using it in a long-term setting, you don't need to monitor for the thyroid function, liver function test in our practice.
Fantastic. Thank you, Mark. The next question I think is really directed to Allison concerning heart block. There's two questions from Stella Mongela. What is high-grade second-degree block is the first question. And the second is, while waiting for those 7 to 10 days for heart block to resolve after surgery, is there anything else that can be done? And in particular, is there any role for steroids?
Those are great questions. So high-grade second-degree block, I think people typically use it when there's more than one dropped P waves in a row, but it's not necessarily specific in what it means. And then in terms of while waiting for a post-operative heart block to resolve during those 7 to 10 days, ultimately the benefit from steroids has not been clearly demonstrated, and it is certainly controversial, but it has not been clearly demonstrated, while there is some morbidity involved with giving steroids in the postoperative setting. So we, at least at our institution, don't typically give steroids after a surgical heart block is created. I don't know if anyone else wants to comment, if you guys have a different approach.
We don't give steroids either. No.
Same. Yeah, we do not.
I mean, I think the only role for steroids possibly is post-ablation, where there's a question about whether or not post-ablation, if there's some injury inflammation around the AV node. And there's a little more data for that, and you haven't obviously got a great big stenotomy that's trying to heal at that point as well. So some people would give steroids in that scenario. I don't know about the others here, but it's certainly something I've seen done. I've never done myself. And then, but post-surgical, no steroids.
Yeah, that's a good point. And then also, that brings up the idea of post-calf injury. And we actually do tend to give steroids post-cath, and the same idea of the morbidity of giving it is low, and there may be some benefit if there's been some kind of transient injury to the area from manipulation of catheters or devices.
Yes, certainly in the interventional world, that's gained increasing traction over the past couple of decades for things like VSD and ASD closure. Unfortunately, we don't have a lot of good literature, which is so true for so much of what we do. But anecdotally, there's several reports from all over the world about patients getting better with steroids, whether that's just temporal or that's casual. We don't know, but it is, as you say, Allison, it's kind of something people do.
Yeah, there's good questions rolling in, so thank you everyone for posting your questions. I think there's a good provocative question here, and maybe this will be managed differently across different centers. So everyone, please feel free to chime in. But it's talking about a pre-Fontan patient who has SVT episodes with high risk of AV block if they were to go for an ablation because of their size. So really, it's sort of the management strategy for that. What would be the best way forward? Go ahead with the Fontan and monitor for arrhythmia, or ablate it if they develop AV block, do the Fontan and a pacemaker. Who wants to tackle that?
I'll start. That's a tough one.
Yeah.
I think our policy here is if someone's had SVT prior to their Fontan, we go for EP study. And I think maybe that's the differentiation. You know, you can basically do a full EP study and bail out of ablation at the very last second if you really think it's high risk. So I think most, our idea is map where it could potentially be. If it's not high risk, then do everything we can to take care of it. If it is high risk, then have that discussion. So it's significantly more difficult to take care of something after a Fontan via ablation. So before Fontan, you kind of have access to the whole heart from the groin. After Fontan, we have to bring in the Evans and the Darrens of the world sometimes to help us get to places where we need to be.
Yeah, Anna, do you want to comment? I know that together we've managed a handful of these type of patients over the previous years, and thoughts on this?
I would really kind of echo what Tony had said, in that we will absolutely study anybody who is pre-Fontan who's had neonatal SVT, regardless of the known mechanism, because oftentimes we just assume it's a pathway. And what you hope for is that I think you have a left lateral accessory pathway, that you can get rid of, and not that you have something septal and would be a risk to the AV node. But again, you go in there and see what you can, what you have, and then ablate it if it's reasonable to do so. But certainly I would be cautious about risking the AV node. I think 100% ventricular pacing in a single ventricle, we all would agree, would be less desirable than medical therapy.
Yeah, absolutely. I mean, we've got data on pacing in the Fontan group now across about 200 PACE patients, and they look to be about 10 times higher risk of deterioration to Fontan failure or death. So I think I would certainly steer very hard away from AV block and tolerate SVT instead, if that was your two options. But absolutely would cross fingers and hope that you can ablate and get rid of it, and that would be the ideal outcome. But the Fontan group is one I'm particularly worried about when it comes to AV block as a complication of ablation.
Great, that's really helpful. The questions are great, as Darren said. It looks like the last two I see listed here would go back to you again, Allison, in terms of heart block. But everybody, feel free. We know there are institutional differences when it comes to things like this, and I think it'd be really beneficial to hear if people have different approaches to this. The first one is in neonates with the permanent pacemaker for complete heart block. Does it need to be replaced when it's older? I'm assuming they mean the wires and the generator. And the second question also relates to a small neonate. What's the smallest neonate that can receive an epicardial pacemaker for congenital heart block?
Great questions again. So yes, ultimately a pacemaker does need to be revised over time. The battery does run out. And depending on all sorts of different factors, batteries can last from a couple of years to close to a decade. But ultimately, the battery always does need to be serially replaced. The leads that are sewn onto the outside of the heart can break or can become not as well functional. And so ultimately, when a patient is older, and this is probably around the time when they're about 20 kilos, we transition them from an epicardial pacing system to a transvenous pacing system if they've got a structurally normal heart. And with that, the leads go onto the inside of the heart and they're a bit more protected. And so there's lower risks of lead fracture like that. But yes, the system does need to be revised over time. And the second question of what's the smallest neonatal weight that can receive an epicardial pacemaker for congenital heart block? You know, that's a great question. I think it depends more on the surgeons. We like to get our infants closer to 2 kilos if we can, but I've certainly placed pacers for infants that are much smaller than that. And I know there have been reports of very, very small infants who've had pacemakers placed. Do others have a kind of an idea of a cutoff for what they like for smallest neonatal epicardial pacing system implantation?
I think a lot of it is surgeon dependent, isn't it? And whoever's putting it in. I know some will take the approach of putting in temporary pacing leads for the ones who are sort of under 1.5 kilos, buy a bit of time. And then you also have the potential of getting this kid a bit bigger if the temporary pacing leads work well, that you can go to a bipolar rather than unipolar. So 2 poles of your pacing lead rather than just a single button, which gives you a bit more flexibility for the future. And you can get better placement as well. So that's the alternative approach, is to try to buy a little bit of time. But yeah, certainly it's described well under 1.5 kilos, but the complication rates go up significantly.
Thanks. There's another, and this looks to be the last question. And maybe perhaps I'll direct it to Anna first and then open it up to others to comment. I was always amazed at the colorful 3D stuff that I would always see in Anna's EP lab. And it's a question from Mohammed Saleen about routinely using 3D mapping for pediatric ablations, or a yes or no, or where you may see the utilities in that.
Yeah, I think certainly those of us trained in the States, I think, are very commonly using 3D mapping. And in fact, honestly, I didn't train using fluoro. So when our mapping system went down, I didn't know if I could do a case. But there are absolutely centers who don't have access to it or don't have access to it every day and would do a standard SVT ablation with fluoro guided imaging. And I think there's nothing wrong with that if that's what is available.
Others?
I think with, I routinely use it, but I think really success rates are almost identical and complication rates are almost identical, whether or not you use it for accessory pathways and AVRT, certainly. So if a center doesn't have a 3D mapping system, but you have a great, or you have the ability to do EP studies, then I don't think it's absolutely necessary for straightforward SVT. You just use a little bit more fluoro.
Well, and I think in our field, we have this minimal fluoro approach, but the truth is, if you have a structurally normal heart and a garden variety SVT, you're doing one procedure, most likely. It really is a small fluoro time. It's not, Darren, like your PA rehabs where you're constantly irradiating them over their life,
Yeah,
All right. Thank you for the answer to that. Are there a few more?
There is one more.
Yeah.
A few more questions coming in.
Take it, Evan. Go ahead.
Yeah, we'll answer a few more questions. Then I suspect people will have to get on with their day. What will be the best approach in the management of non-sustained ventricular tachycardia and frequent premature ventricular contractions in children and patients with normal hearts versus those with congenital heart disease? I just open that up to whoever wants to jump on that, other than me and Darren.
I guess I'll jump in. For PVCs and structurally normal heart, for the most part, it's a benign, issue. And so you do want to make sure that the PVC is suppressed with exercise and that the patient's function is generally normal. But for the most part, those don't require treatment. And maybe it can open it up to my colleagues here too.
You have to say I'm very driven by function. For me, there needs to be impact on function, which tends to only occur, once you've got a really substantial PVC burden, upwards of 20%. I have had patients who've been referred in who have been intensively monitored and exercised 3 or 4 times a year, and it disrupts every part of the day, where they come in, they're desperate to have an ablation for PVCs, and the actual work is to persuade them they don't need it, that trying to just sort of wind down that level of anxiety about the PVCs. I think non-sustained VT is kind of a different question in many ways. That's a puzzle for me, and I don't know how the others feel, but we are picking up increasing amounts of non-sustained VT, and coincidentally with longer and longer periods of monitoring. So we use the Zio patch a lot, and there are other ambulatory ECG monitor patches that people can wear for upwards of a week. And so you have that much more time, and therefore you get that much more coincidental pickup of an episode of non-sustained VT, which they don't even feel. And I try very hard to ignore it in the best possible kind of way, but it's I think the jury is still out there of the best way to manage that particular question. So I see them as 2 kind of different things. PVCs and non-sustained VT are not necessarily going hand in hand.
Yeah, I know we're running a bit over, but I think why don't we throw this last question out there, given the life and world we're all living in now in the time of a pandemic. It's a very pertinent question. And have you seen complete heart block because of COVID-19 myocarditis, which has led to permanent pacing?
We have seen complete heart block, but not that has led to permanent pacing. So all of it has been transient. Have others seen anything beyond that yet?
Likewise, so transient, but no permanent pacing yet.
And we had one that we did end up needing to permanently pace, but she also had a cardiomyopathy, so it was unclear how much of the impact was COVID versus cardiomyopathy.
Mm-hmm.
That's great. So for the first few just sort of final words, thank you to all the speakers for really, really great, thorough talks. We challenged you with big topics to cover in a short period of time. So thank you very much for that and for your contributions. It means a lot to us, and I think to all of the attendees. Secondly, the biggest thank you to all the attendees from around the world to tuning in what is an evening and nighttime for probably many of you. So thank you for all of your attention and provocative and thoughtful questions.
Yeah, I just want to echo, we all go to a lot of meetings, and those were really world-class, phenomenal talks. Thank you, guys. That takes a lot of time and effort, and we really appreciate you doing this on behalf of Mending Kids and our colleagues overseas. We all very much sort of miss getting together in person, particularly coming over and working with our African colleagues, and hopefully things will get better as the year and years go on. In the interim, this is the best we have, and I think meetings like this will keep us together as a community and serve our patients as best we can during these trying times. So thank you everybody for joining, and I want to turn it over to Isabel Fox, the director of Mending Kids, for closing comments. Isabel?
I can't add more than what's been said today. I'm just very grateful for everybody who took the time to volunteer to present today, for all of you for taking the time to participate in the symposium. It just brings us all together, like everyone said. And it's so critical to us in the future of these symposia that you fill out the survey that is in your inboxes right now in your emails. If you just take 3 minutes to open your emails and fill out the survey, it will be done. The recording of today's presentation will also be available, and we'll be sending you a link. And I just want to say to our colleagues in Tanzania and Kenya, asante kwa kujiunga na madaktari wetu na Mending Kids leo. So thank you all for joining our doctors and Mending Kids today. And usiku mwema. Good night.
Bye, everybody.